Good evening. My name is Dr. Kevin Chua, a radiation oncologist from National Cancer Centre, Singapore. First off, I'd like to thank the organizing committee for inviting me to speak here today. The topic of my discussion is combining systemic therapies with spine SBRT. These are my disclosures, which are not related to my talk today. So in recent years, we have seen spine SBRT really come to the forefront of cancer and metastases management, leading to dramatic improvements not just in pain responses, but also in terms of local control. But we do know that a great proportion of these patients will ultimately fail where they have been related before. For instance, in the Sabre Comet study, which is widely reported, about 35% of the lesions which were ablated in the SBRT arm were from the bone. And these bone lesions were all treated with fairly good doses, 35 gray in 5 fractions, 30 gray in 3 fractions, and single fraction doses of 16 to 20 gray. And we know that at median follow-up of 51 months, about 30% of these bone lesions had recurred. In our institution, we tried to identify imaging features that could predict for a poorer local control. And we found that patients with disease extending across multiple levels and patients with significant paraspinal component in their spinal disease essentially had a poorer local control at 1 year. And the reason underlining this is actually the problem of tumor radioresistance. Broadly speaking, we think of tumor radioresistance as being primary innate radioresistance, where essentially there's a very short disease control period post-radiotherapy, or it can be acquired radioresistance, where essentially there's a period of disease control followed by tumor recurrence. And underpinning these broad categories of radioresistance are essentially various key mechanisms. For instance, some tumors can have a very abnormal DNA damage response. And what this means is that they can tolerate high levels of genomic instability and continue to maintain the pro-survival pathways. At the same time, we know that radiotherapy can also lead to modifications and remodeling of the stroma, the tumor microenvironment, changes in the vasculature. And sometimes what this sets off is this perpetuating proliferative signaling loops that can ultimately create the environment or the perfect storm that can lead to tumor recurrence. Finally, we know that radiotherapy can set off an immune cascade. Sometimes what happens is that, as a downstream effect of the immune cascade, radiotherapy actually leads to an immunosuppressed tumor microenvironment. And over time, immune escape mechanisms can kick in and tumors can recur. And this last particular mechanism has garnered lots of attention of late. One of the reasons for that is because manipulating the immune tumor microenvironment post-radiotherapy has led to some preclinical as well as clinical successes. And so that's generated a lot of interest. In general, we think that there's synergy between radiotherapy, in particular SBRT, and immunotherapy. And we think of this synergistic interaction as being somewhat dependent on, for example, the context, whether this is polymetastatic disease, oligometastatic disease, or oligoprogressive disease, where essentially you're trying to overcome acquired resistance. We think of this synergy as being somewhat treatment dependent as well. The type of immune checkpoint inhibitors that you're using, whether it's anti-CTLA4, anti-PD-L1, or so radiotherapy related treatment factors such as, for example, dose perfection. Where we know from Dr. Fermenti's team that was published in Nature Communications in 2017 that dose perfection correlates with upregulation of Tregs, which then leads to essentially how the availability of cytosolic DNA that can set up your C-gasting pathway. And so things like dose perfection can actually alter your immune stimulatory response. We think of this synergy between RT and immunotherapy as being somewhat sequence dependent as well. For example, if you're using immunotherapy concurrently with radiotherapy, then potentially what's happening is that radiotherapy sets off all these cytosolic DNA, this DNA debris, which essentially provides a lot of new antigens for the T cells to feed on. At the same time, the concurrent use of immunotherapy can make the priming of these new antigens much more efficient. A lot of patients would already have had some immunotherapy before radiotherapy, and we think that in that context, these patients would have already primed immune microenvironments, and then perhaps the radiotherapy, the addition of radiotherapy gets rid of resistant clones or essentially reinvigorates exhausted T cells. Or, as alluded to before, we know that radiotherapy can lead to upregulation of, for example, anti-PD-L1, create an immunosuppressed tumor microenvironment, and then the additional immunotherapy after radiotherapy can again tweak and alter the immune microenvironment in a way which enhances further the effects of radiotherapy. And so, we think that, essentially this synergistic interaction can be very context, treatment, and sequence dependent. There's a lot of interest in testing these theoretical benefits in a clinical setting. And a lot of that has to do with the fact that in recent times, you're starting to see a lot of immunotherapy as well as immunotherapy combinations move into the first-line setting, and a lot of metastatic disease for various tumor types. Now, we've already seen the benefits that we can get from adding SBRT to all sites of oligometastatic disease in a setting of sort of conventional systemic therapies. It stems from that when the systemic therapy is immunotherapy, then potentially the addition of SBRT can be further can lead to benefits which are further enhanced. So on this point, I point you to this excellent editorial in the Red Journal by Dr. Gutentov and Professor Weishampel, where he makes several compelling arguments about why the immunotherapy SBRT combination makes sense, particularly in oligometastatic disease, and that you should really go after and treat all sites of disease. One, there's already evidence to support SBRT in oligometastatic disease. Two, we have some evidence that immunotherapy seems to work best in patients with limited disease. For example, in melanoma, patients with small volume disease tended to have higher overall response rates. Similarly over here, tumor load below median led to improved response rates as well. At the same time, we have seen examples of that in the Pacific study. So the Pacific study was actually done in the context of stage 3 non-small cell lung cancer. And for those of us who manage stage 3 non-small cell lung cancer, we often know that a great proportion of these patients would actually fail in new distant sites. And really, many of these patients actually have occult metastases. And so, in a way, stage 3 lung cancer is really occult, oligometastatic disease. And in the Pacific study, following maximum cycle reduction with chemoradiotherapy, the addition of adjuvant durvalumab actually led to an improvement in overall survival of about 10%. Along with that, you also had improvements in local control as well. And this benefit persisted all the way at long-term follow-up. And so all this is very exciting and further supports the point that in patients with limited low volume disease, patients who have been maximally cyto-reduced, this is where potentially immunotherapy can work its magic the best. Three, again, to support the use of SBRT immunotherapy combinations in oligometastatic disease, we know that in keeping with similar patterns of failure following other types of systemic treatments, we know that patients tend to fail in pre-existing sites of disease. Finally, we have started to see some early evidence of this SBRT immunotherapy synergy in small studies. For example, in this study by Dr. Fomenti, this was done in non-small cell lung cancer again, and what she found was that so the systemic agent that was used here was anti-CTLA-4. We know that anti-CTLA-4 alone responses in non-small cell lung cancer, it's not great. At the same time, what they found in this study was that the addition of concurrent SBRT to anti-CTLA-4 blockade essentially led to a good proportion of patients actually having responses, which is rather unusual. And in these responders, what they found was that there was these early dynamic changes, expansions and contractions in T cell clones, and a lot of it was actually driven through interferon gamma. In support of this, there was one particular patient where there was this expansion of a particular T cell targeting one particular neoantigen, which had been upregulated following radiotherapy. And so, this is early evidence, small studies, but it further supports some of the preclinical theoretical benefits that we've alluded to before. At the same time, we are starting to see other studies, for example, this one by Dr. Thielen, where again, non-small cell lung cancer, single agent pembrolizumab in the context of polymetastatic disease. They picked one site and they applied single site SBRT. And what they found was that essentially there was a trend towards improved progression-free survival. And interestingly, a lot of the benefit seemed to be driven by the PD-L1 negative arm, which is traditionally the group that you would have thought would not respond so well to single agent immunotherapy alone. And so again, this further supports the point that there is some early signals, there's some small signals of synergy, of benefit there. Potentially, if you then radiate all sites, maximally cytoreduce these patients, then potentially you can really see the benefit of SBRT in oligometastatic disease that we've seen before. Of course, in our clinic, many of the patients that are referred to us would have already been started on some immunotherapy or immunotherapy combination, and are often then referred to us for SBRT for oligoprogressive disease or for symptom control. And so within our group, we actually developed a protocol in this particular oligoprogressive setting, and we carried out a study where essentially this was a cohort of patients who had already had some prior response to immunotherapy, developed oligoprogression, and then we offered SBRT. But in the context of this study, we performed immunophenotyping before and after to sort of detect some of these shifts in the circulating tumor, circulating immune environment. The basis of this was actually from this pilot where we had one particular prostate cancer patient. We performed SBRT to one oligo metastatic pelvic lymph node, and then we subjected this patient to immune phenotyping before and after radiotherapy. And in this particular patient, we actually found, to our surprise, very dramatic shifts in the circulating T cells as early as time point B, which is 2 days, and essentially it persisted to time point C, which is about 1 week post radiotherapy. And so we could see these dramatic shifts just following radiotherapy alone. And so extending from that, we thought these are already patients who have been pre-treated with immunotherapy. Could we potentially detect an interaction following the introduction of SBRT that we can then pick up through very specific high-dimensional immune profiling methods. The reason why we profiled the circulating T cell component as opposed to tumor phenotyping was because this was a histology agnostic study. We were also recruiting patients who had SBRT to various sites, and so what we were doing was really we were actually looking out for commonalities in the host systemic immune response. Another question that we often have in this study was, why did we pick the time points of 1 to 2 weeks? And the basis for that is really stemming from some of the earlier experiences following vaccinations, acute infections, where we can see the expansion of some activated T cells about 1 to 2 weeks following antigen exposure. And then we thought, perhaps in radiotherapy, the setting of radiotherapy, could we be potentially dealing with a similar kinetic of circulating T cells over here? And so we went about this study, and we collected patients 20 minutes of blood before after radiotherapy, as well as after the reintroduction of immunotherapy, we performed mass cytometry-based high-dimensional immune profiling. So what that means was that this was a single cell interrogation, and we essentially looked at 40 different intracellular and extracellular phenotypic markers. And these markers all represented, for example, markers of various T cell lineages, and also markers of differentiation, activation, co-stimulation, inhibition, trafficking, as well as cytotoxicity. So basically, it could give us a very granular picture of what's happening at a very functional level. And right off, we could see that there was this clinical benefit in patients that had oligoprogression that were then treated with SBRT. Not surprisingly, we could see very dramatic local responses. So, for example, we have paraspinal bony rib lesions that, following 24 Gray in 2 fractions, even at the first imaging time point, had complete responses. And so this to us was, rather unsurprising, but again, sort of alludes to the fact that there is this synergy between RT and immunotherapy. At the same time, there was a hint that the additional SBRT in this context was also altering the disease trajectory. For example, we could see that essentially some of these patients, we compared their time to progression before and after the introduction of SBRT, and we could see that for some of these patients, the time to progression after RT was actually prolonged relative to the time to progression before RT. And for some of these patients, they then actually went on to receive immunotherapy and continue to respond to immunotherapy for more than a year. So all in all, we could see that there was this clinical benefit from adding RT to immunotherapy in this context of oligoprogressive disease. We then dissected the systemic immune landscape, and we first did this by sort of looking at the frequencies of T cells and NKT cells, and we looked at this from we started off first just by looking at the various stages of T cell differentiation. And what was very interesting to us was that at baseline, we found that essentially our patients had very diverse immune states. And this was even before the addition of radiotherapy. Following radiotherapy and following the reintroduction of immunotherapy, we could see that there was some individual patients with dramatic shifts in specific cell subsets, but again, there was no clear trend. Now, one of the questions that we asked ourselves was, essentially this diversity, this heterogeneity at baseline, was this because we had, essentially recruited patients from different tumor histologies? We then actually recruited a second cohort, which was a more homogeneous cohort consisting primarily of prostate cancer patients. And we found that it was a similar picture. In this cohort, even at baseline, again, the immune states were very diverse. And again, following radiotherapy, there was no clear trend, and essentially it was all a very heterogeneous systemic response. And so we looked at some of the earlier reports, and we found that essentially there were some studies that found upregulation of a certain Ki67 positive activated effector differentiated T cells, CD8 T cells, and they were able to correlate that with response to checkpoint inhibitors. And so we speculated that potentially, if we looked at these particular activated Ki67 positive CD8 T cells, we could see a similar upregulation following radiotherapy. And what was very exciting to us was that essentially this proved to be the case. And from baseline, essentially patients who underwent radiotherapy had this expansion of these Ki67 positive activated T cells. And when immunotherapy was reintroduced, this expansion was further sustained and continued to increase. And what was also very interesting to us was that when we when we looked at the phenotypic profiles of these particular T cells, we found that actually RT did not change the phenotypic profiles of these T cells. It merely did that. And so, potentially these T cells, this particular profile were already there before, and essentially, RT was able to reinvigorate, re-expand them, and essentially, hopefully trigger off a continued response to immunotherapy. And finally, while we were not able to sort of correlate that with any particular clinical response, because this was a small study, the fact that we had this common systemic immune response across tumor histologies, across different radiation sites, was actually very exciting to us. And so, in the future studies, when we have a cleaner cohort, potentially we know that this is a good place to start looking if we are looking to interrogate again the systemic immune landscape. Finally, as with all combination treatments, we always have to be very mindful of some of these adverse events that can stem from interaction between all these different modalities. Personally, there are a few novel agents which I pay more attention to. Right. For example, we know that specific to immunotherapy, patients who have prior immune-related adverse events to immunotherapy tend to be at greater risk of some of these immune-mediated post-radiation adverse events. For example, in this study that was published in Annals of Oncology, what we found was that essentially in patients who had prior IRAEs, 61% of them actually had grade 2 and above radiation pneumonitis. And so, yes, in spine, we don't tend to, see that much of, immune-mediated adverse events. But at the same time, don't forget, one, we may be treating multiple levels of disease. Two, occasionally we could be coming back to the same area and re-irradiating the same disease site, with short interval of a few months. And three, a lot of times in the context of oligometastatic disease, where we're trying to ablate all sites, we're also treating multiple sites of disease. And so it's always very important to sort of have these red flags in mind, that you can always sort of realize that, are there any specific things I need to pay attention to? Another novel agent that I pay particular attention to is anti-angiogenic agents, bevacizumab, pazopanib, and we've seen some serious adverse events, including fatal events, following, for example, extracranial abdominal RT, or even in lung ultracentral SBRTs. And so again, in spines, sometimes we do end up treating diseases that are a bit bulkier with significant paraspinal component that may extend anteriorly. And so you always need to be very mindful of some of the interactions with anti-angiogenic agents. And finally, one of the other novel agents that I pay particular attention to is some of the tyrosine kinase inhibitors, for example, the EGFR TKIs. We're starting to see that in the third generation or newer generation TKIs, some of these, for example, like osimertinib, can be very potent. And for example, in this Green Journal paper, essentially they found that the concurrent use of osimertinib in thoracic RT led to almost 60% of grade 2 and above radiation pneumonitis. So as we treat multiple sites, as we potentially re-irradiate the same sites over a short time frame, as we grapple with some of these novel agents, it's very important to have a way to essentially rationalize and sort of risk profile your patients and sort of have that difficult conversation with patients. Across the board, between me and my colleagues, we have there's not much clinical guidelines out there in terms of how you should approach these interactions as adverse events. So for many of us, essentially we look at the half-life of these novel agents and we go from there. But at the same time, some of these agents like immunotherapy can have extremely long half-lives. So how do you reconcile all that? And so, for some of us, we actually stop these novel agents during the course of radiotherapy itself. But don't also at the same time don't forget that eventually systemic agents will be reintroduced, and sometimes we know that radiation can also set off this whole cascade of downstream effects, which can still be potentiated by these agents once they're reintroduced. And so, pay attention to some of these agents, have that conversation with the patient, but at the same time, also, follow your patients out very, very closely, and look up for some of these potential adverse events. Finally, I'd like to end off with one patient of mine. This was a patient who had good disease control on osimertinib, subsequently developed oligoprogression 2 sites, spine site, as well as a primary lung tumor. So I radiated both sites. The lung tumor actually received, it was a fairly small fluid, and I gave it 45 gray and 15 fractions. The spine was radiated with 30 gray in 5 fractions. And essentially what happened a month post-radiation was that she actually developed shortness of breath, decreased effort tolerance, and on CT was found to have this grade 2 pneumonitis. If you correlate the extent of the interstitial lung changes with the dose maps, then actually you can see that the doses that are in play, 22 gray, 15 fractions, 15 gray, 5 fractions, that is actually not what we would traditionally consider as very high doses. So it's important to to really look out for these adverse events as we move forward. So fortunately for a lot of my patients, usually I give them an email, they contact me, and especially for this patient, it was quite fortunate that we picked this up early and she responded very well to steroids. So I'd like to end off my talk here. Some key take-home messages. There are many advantages to combining SBRT with systemic therapy, particularly in the oligometastatic setting. We've already seen the addition of SBRT, potentially altering the disease course and affecting patient outcomes. And when you have all that in the context of immunotherapy, then again it makes it even more exciting. Of course, this synergy between SBRT and immunotherapy is not just in oligometastatic setting. We think that even in the oligoprogressive setting, where SBRT can potentially overcome acquired resistance, this is where more work needs to be done. Patient selection is key, and we really need to be aware that there are these potential adverse events that can eventually play out, and so when you sit down with that patient, you really need to rationalize the potential benefits with the potential risk. And with this, I'd like to thank you for your attention.